Good morning, everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here in Insurance Syndicate headquarters, and man, we have a great show for you.
What is happening, man? Welcome to Tuesday Training. That's right. It is time. And man, we got a deep one for you today. If you're out there in the Medicare space, you definitely want to tune in because we are going to dive deep into the newly released proposed rule for 2026. Yes, that's right. You probably already heard about it. A few people have been chattering about it. It was released November 26th. This is just the fact sheet. This post is already in the group. This little fact sheet article, you can find that. And that article is also a link to the Federal Register, which has the entire 714 pages, if I remember correctly, of the proposed final rule. So you can look through that. But I've taken quite a bit of time to dive into it. It's got 9 major points, and I am going to run through it in some pretty massive detail for you guys. There's definitely some things to be concerned about in it, but there's a lot of hyperbole around it too. And I think a few people might be a little over dramatic on it, but there's definitely some gotchas that we got to look out for. Now, before I dive into it, I should also preface that this could all be moot, right? Because we have a new administration come in. We have a new director of CMS, Dr. Oz. Say whatever you want about that. I don't even know how to react to it at the moment. So this could all be moot, right? We may very well see a lot of this stuff get thrown out, whether or not they're going to throw out the baby with the bathwater, so to speak, or just cut little pieces out of it, et cetera, et cetera. I mean, if I were to speculate, I would say we're probably going to see less regulation next year, and we're going to see things start to get a little more smoothed out for us. I could be wrong. I've been wrong before, and I don't have a crystal ball. But what I have done is I've gone through this rule in great detail, and I'm going to go through a lot of it with you. Some of it is definitely redundant. There's a lot of redundancies in there for things that they've already done. There's a few minor adjustments to little things that are starting, like, for example, with the Inflation Reduction Act, right? There's areas of it that graduate over the years. A couple of those are included in here. Nothing massive in that regards. The big things that obviously the agents are concerned about are the things related to marketing communications. And you should be, because there's definitely some updates in there that could certainly, like I said, they're worth concern and they're worth commenting. I also have all of the different contacts to comment on this CMS proposed final rule. I will make sure, and those have actually, in the post that has the fact sheet, I included all of that, I believe, in the comments. It might be in the main part of the post, I forget. But that is all in there. It has everybody's contact information that you can contact and leave comments for. Whether or not they pay attention, I don't know. I would say it is definitely worth your time to comment. I definitely plan on making comments. I definitely plan on writing all of our representatives, or at least my representatives, and talking about it and so forth. But before I dive in, I just want to give a quick shout out to the guys over at DFY CRM. It is the CRM of choice for me. I've been using it for years, love it to death. It's outstanding. They just recently did or released a training on how to utilize AI to help you create Facebook ads, video ads. All of that stuff is incorporated with DFY. You can manage all your Facebook ads through it, et cetera, et cetera. Phenomenal platform. They did a Black Friday sale on it. You'll find it in the group. Go check that out. And with that said, let's dive into this thing. So I'm not going to screen share anything with you. I've got my notes that I'm going to go through, and I'm just going to sit here and lecture, so to speak. You may want to make some notes, I don't know, or just listen and think about how some of this may or may not affect you. But starting right at the top, like I said, there are 9 primary points in those 714 pages. And those points are: number 1, cost-free vaccines. Number 2, affordable insulin. Number 3, easier drug payments. Number 4, obesity medications. Number 5, health equity. That one's pretty deep. We're definitely going to dive into that. Number 6, there's some new updates on dual eligible plans, or new requirements, I should say. And then the 3 big ones that we as agents are generally concerned about. Number 7, or actually 7, 8, and 9 are all around promoting informed choice. Promoting informed choice to the beneficiary. And they've got 3 areas in wanting to improve the promotion of informed choice. The first one is to format provider directories for the Medicare Plan Finder. The second one is to expand agent and broker requirements regarding Medicare Savings Program, Extra Help, and Medigap. And the final one, the one that most of us are concerned about, is enhancing the review of marketing and communications. So I've gone through each of these sections with a pretty fine-tooth comb, pulled out some points that I want to cover with you, some things that are going to clarify and remove some of the hyperbole and fear-mongering that's out there. And certainly we're going to point out a few things of note and of concern. But jumping right into it, these first through a few are going to go kind of quick. Free vaccines, what the hell are they talking about? Pretty simple, right? They are now giving out free vaccines. What vaccines are covered? Well, shingles or zoster vaccine, previously expensive under Medicare Part D, is now $0. Pneumococcal vaccines, right? Protecting against pneumonia. Hepatitis B vaccine, right? Different COVID-19 vaccines, which are already cost-free under Medicare, but they're emphasized in this rule redundantly for more clarity. And then certainly the regular old flu vaccine covered under Part B, not Part D, but Part B, but now also free. So, the main thing there is they're basically just removing the co-payments for these different vaccines. They are called ACIP vaccines, which stands for Advisory of Committee on Immunization Practices. So any vaccine that the Advisory Committee on Immunization Practices, ACIP, deems qualified under them and the CDC, they will be included, but those are the main ones: shingles, pneumococcal, hepatitis B, COVID, and influenza. Pretty simple, right? All Part D plans must include the ACIP recommended vaccines on their formularies with $0 out-of-pocket cost. Fairly simple, right? And plans cannot impose prior authorization or utilization management on these vaccines. Pretty simple there, right? So I'm not going to jump into that one too big. One of the biggest, I would say, the health goals for doing this is obviously disease prevention, right? Providing people good access to vaccines at a very low cost, $0 cost, is going to make sure that they can help prevent vaccines. Taking that a step further, theoretically, is going to reduce cost for Medicare, because if they can prevent disease, they would reduce the overall healthcare spending by lowering the need of treatments, hospital stays and complications, yada, yada. Fairly simple. Next one is affordable insulin. This one was mostly redundant stuff. I didn't find a ton of stuff in there that's new, but there was one piece that stood out to me. And I don't know if this was in the previous rule or if this is specific for 2026. I believe it is specific for 2026, the way it's worded. But I'll just read it to you, because we already know there's a $35 cap on insulin, right? That was part of the Inflation Reduction Act. It's like, hey, let's make sure insulin's available at $35. It's a mandate for all Part D sponsors for any insulin on their formulary. $35, period, end of story. So they have a new thing. For 2026 and every subsequent year, in accordance with this statute, we are proposing that with respect to a covered insulin product covered under a prescription drug plan or Medicare Advantage prescription drug plan, prior to the enrollee reaching the out-of-pocket threshold, the covered insulin product applicable cost-sharing amount is the lesser of $35 or an amount equal to 25% of the maximum fair price established, or an amount equal to 25% of the negotiated price as defined. So in other words, if the insulin is on the formulary starting in 2026, assuming all this goes into play, then the price will either be the lesser of $35 or 25% of either the negotiated price or the maximum fair price. So I don't know if there's any insulins out there that after a negotiated price, 25% of that price would be less than $35. If it is, then they could pay less for their insulin, right? But the most they would ever pay is 35 bucks. But now they have a situation where if 25% of the maximum fair price or 25% of the negotiated price is less than 35, they would pay that number. Pretty simple update there. Not a big deal, right? Some of the implementation requirements on that, obviously Plan D or Part D plan sponsors must include insulin products that meet the cap on most of their formularies. They must provide these products without requiring beneficiaries to meet the deductible first, right? So the $35 insulin cap is not included in the deductible portion, right? They get 35 right up front without having to meet that deductible. Pretty simple. A few enforcement mechanisms, right? CMS will ensure by monitoring plans to confirm the insulin products are appropriately priced, et cetera, and they will penalize plans that fail to meet these requirements, including fines and/or suspension of Medicare contracts. Fairly simple one there. Third point is easier drug payments. This is going back to the 12-month Medicare payment program or prescription payment plan, right? The MPPP or whatever the hell they're calling it. We already know most about that. There's not really much to say in this, but I want to go through a couple of things on the implementation and the Part D sponsors' responsibilities, right? They must ensure that this option is available to all enrollees who face high out-of-pocket cost. They must inform beneficiaries about their right to request payment smoothing, as they're calling it, and how to enroll. So again, the education of the beneficiary is that responsibility is on the carrier, right? It's on Humana, it's on Aetna, United Healthcare, any Part D plan sponsor. It's their job to inform all enrollees that plan is available, or that system is available, I should say. They have to manage the billing. They got to set up systems to handle the administrative aspects of installment payments, including tracking the total amount owed, adjusting monthly payments if additional costs are incurred during the year, preventing late fees or penalties for beneficiaries participating in the smoothing program. Beneficiaries' rights and protections under this. There's no penalties for opting in. Beneficiaries cannot be penalized or charged extra for choosing the payment smoothing option. Flexible enrollment. Beneficiaries can choose to enroll in or opt out of the program as their financial situation changes. And plans must provide clear and accurate information on how much the beneficiary owes, how long the payments will continue, and any adjustments to the payment schedule. What might be a few challenges? Because there could be some implementation challenges on this, right? There's obviously administrative complexity because these plan sponsors under Part D, they now have to create new systems to handle all this reporting, right? So we're going to see some administrative costs go up for them, which we already know is a big part of why we saw Part D premium bids come in at 300% last year before they added their new little subsidy to them. So there's some of that for you. Let's move on to the next one. Where'd it go? I got them all highlighted here. The next one, obesity medications. This has been on the news quite a bit. They are now looking at expanding the Inflation Reduction Act to now cover obesity medications, GLP-1s, as they are called. What are the proposed changes? Well, CMS is exploring allowing Part D coverage for weight loss drugs deemed medically necessary for treatment of obesity, emphasizing that such drugs must meet standards for safety and efficacy set by the FDA. So their focus is now on treating obesity as a chronic condition, acknowledging obesity as disease rather than a lifestyle choice. Recognizing that effective treatment often requires a combination of medication, behavioral counseling, and lifestyle changes. I want to read that again. So it's not just, the way I'm understanding this is not that it's like, hey, look, cool, we're going to give you obesity drugs. That's great. Inject that, lose some weight, be good. No, the effective treatment is going to not only require combination of the medication, not only going to require use of the medication as far as approving it, but it's also going to have to include behavioral counseling and lifestyle changes. So the way I'm understanding this is if they want to get that drug covered, they're going to have to get with the program, make some lifestyle changes, get some behavioral counseling on how they can also affect their obesity challenge, right? Fairly simple there. What's the rationale? Obviously, health benefits, because obesity increases the risk of multiple chronic conditions, including type 2 diabetes, cardiovascular diseases, certain cancers. So the idea is that if they can address obesity, and especially if they can coordinate it with behavioral counseling and lifestyle changes, the idea is that they can reduce Medicare spending by reducing chronic conditions. That's the whole idea behind this, right? Fairly simple. Criteria for coverage. Medical necessity. The medication must be prescribed by a healthcare provider as part of a comprehensive obesity management program. Beneficiaries may need to meet clinical criteria such as body mass index, BMI, above certain thresholds, or the presence of obesity-related comorbidities. FDA approval. Only the FDA-approved medications for obesity treatment would be eligible, and those medications must demonstrate safety and efficacy in clinical trials. Part D plans would be required to include a range of obesity medications on their formularies, subject to standard utilization management tools, such as prior authorization or step therapy. So as we already know, right, all Part D plans are required to include, I believe it is at least one drug from every category. Might be two, I forget off the top of my head. So this is another thing like, hey, now you're going to have to include at least one obesity drug that's on the FDA approved medication list as part of their formulary, assuming that this goes into effect. Here's some challenges, cost concerns. Obesity medications are expensive. Many of them are exceeding $1,000 a month, so expanding coverage could significantly increase Medicare spending, requiring budget analysis. There is potential overuse, concerns about inappropriate prescribing or overuse of these medications, particularly if they are viewed as a shortcut to lifestyle changes. So instead of, I don't know, putting down the fork and getting on the treadmill, if you're just like, oh, just shoot me up with some GLP-1s, I'm good to go, bro. Right? That's why they're saying, hey, this has to be a comprehensive obesity management program where GLP-1s are included, along with behavioral counseling, along with lifestyle changes. All that's part of it. It's not just the ability to give someone GLP-1s and get them thin again. Utilization management, Part D plans can certainly include their risk controls, prior authorization, step therapy, etc. Fairly simple. Moving along to the next one. We're doing pretty good on time because the next couple are going to get long. Next point is in regards to health equity. They have new rules that will aim to ensure fairness and access to care for disadvantaged groups. Well, what is the definition of health equity? Health equity refers to ensuring that all individuals, regardless of race, ethnicity, income, geographic location, disability, sexual orientation, gender identity, have fair and just access to healthcare services. The CMS proposal aims to address systemic barriers that lead to health disparities among Medicare beneficiaries. What are some of the key initiatives? Well, number one, enhancing data collection and analysis. Now, if you're out there in the Medicare space like I am, and you're writing on platforms like Connecture or Sunfire or some of these other ones, you probably noticed some new questions that are already in this direction. And I know some of you have expressed your discomfort in asking your 77-year-old beneficiary what their gender identity is. Thankfully, it's an optional question. That may not be the case anymore. Those questions may not be optional going forward in 2026, assuming all of this goes into play. So again, improved demographic data. CMS plans to require Medicare Advantage and Part D plans to collect more detailed demographic data on their beneficiaries, including race, ethnicity, language preference, and social determinants of health. This data will allow CMS to identify disparities in healthcare access, quality, and outcomes. Health Equity Index. CMS proposes creating a Health Equity Index to measure how well plans are serving disadvantaged populations. Plans performing well in reducing said disparities in the healthcare access, quality, and outcomes might receive higher star ratings. So they're looking at taking that health equity index measurement, however they're creating that, and they're going to insert it into star ratings. So the carriers, the plan sponsors that do a better job at removing disparities for disadvantaged folks in healthcare and improving that access, it could affect their star ratings in a positive or a negative if they do bad. Culturally and linguistically appropriate services. Language access. Plans must provide materials and communications in languages other than English for beneficiaries with limited English proficiency. United Healthcare is way ahead of the curve on this one, in my opinion, and a few other carriers certainly doing well at it. Cultural sensitivity. Plans are required to train staff and providers to deliver care that respects cultural, social, and linguistic needs. So they're going to add in some training requirements for plans and providers. Expanded access for underserved populations, geographic equity. CMS will assess whether plans adequately serve rural areas or regions with historically limited access to care. Plans may need to expand their networks or offer enhanced telehealth services to address these gaps. Weren't they just talking about reducing telehealth services? And now here they're saying we have to now enhance them again. Interesting. Specialized populations. Plans must demonstrate how they serve vulnerable populations, including dual eligible, people with disabilities, racial and ethnic minorities. Social determinants of health. And remember, these are all subtext or subheadings that make up the health equity index measurement that they want to institute, right? Social determinants of health. Identifying the barriers. CMS is encouraging plans to identify and address non-medical factors that impact health, such as access to healthy food, health or housing stability, transportation to medical appointments. Plans may receive incentives for offering supplemental benefits that target social determinants of health, such as transportation, meal, and wellness programs, right? So if Medicare Advantage plans want to receive incentivized payments, more money, they're going to, number one, have to have supplemental benefits that target these particular social determinants of health and prove that it's working. And if they do, they could get extra money. Fairly simple. And again, those are primarily, at least the way it's listed here, transportation services, healthy meal delivery, and wellness programs. You might remember in, I think it was last year's final rule, if I remember correctly, that they were targeting supplemental benefits and saying that, hey, if you want to have a plan that has a bunch of supplemental benefits in it, we want to see, number one, that those supplemental benefits improve health outcomes. They're not just free shit for the sake of offering free shit, pardon my language, right? And that they have high utilization. They don't want to see benefits in there that just look great on paper, but nobody actually uses them, and they don't actually affect your health outcome. So this is just them taking that another step further and now putting it in this health equity index that they're going to add to star ratings. Pretty simple. They want to close gaps in preventative care. Focus on preventive services. Plans must improve access to preventative services such as cancer screenings, immunizations, chronic disease management, particularly again for underserved populations. And they want to pay specific attention to conditions disproportionately affecting certain groups, such as diabetes in the Hispanic population or hypertension in the African American population, right? So they really want to see specific attention to those types of groups that are, as they say, disadvantaged groups, and that they can target those specific chronic illnesses for them and again, improve the health outcome. That's the whole idea. What are some of the implications on this? Well, all the different plans are going to have to develop and implement strategies that reduce health disparities, including initiatives targeting those specific populations that have poorer health outcomes. And as I mentioned, if they do it well, they can receive an improved star rating, which is again going to improve their payments, because plans with higher star ratings, plans that can prove that they're getting better health outcomes out of their enrollees or their beneficiaries will get incentivized payments. All right, moving along. because that's a big one. Yeah, I want to talk about this a little more too. So sticking with the Health Equity Index, because we got some time. It's a proposed tool designed to have Part D or Medicare Advantage and Part D plans reduce health disparities among disadvantaged beneficiaries. So how would it work? Well, again, they want to incorporate into star ratings, right? Here are the key metrics again: preventative service utilization, vaccinations, cancer screenings, chronic disease management. So they want improved outcomes for diabetes, hypertension, cardiovascular disease, especially in populations that experience these disparities. They want to improve access to care. So if you're in a rural area, which may not have the biggest network, they want improved and enhanced telehealth services so that they can reach that group of people. They want social determinants of health interventions plans, and what they're talking about there again, transportation, housing, nutrition. And the key is that data collection and transparency. This is the piece for the carriers that's going to be tough. They're going to be required to collect detailed demographic data, including race, ethnicity, language preference, zip codes, so that they can identify those disparities and track the progress. And then finally, public reporting of the Health Equity Index results could increase accountability and highlight plans leading into equity efforts. I'm sticking with this one for a second because it's one of the deeper ones. Obviously, transportation's an issue. We already know that. That's been addressed. Nutrition's an issue. Housing stability is an issue. Social isolation. Those are your social determinants of health. They want to see improvements in all of those, right? With wellness programs, et cetera, et cetera. But moving along, strategies for addressing social determinants of health. Supplemental benefits. CMS allows Medicare Advantage plans to offer supplemental benefits addressing social determinants of health, such as gym memberships, in-home support services, caregiver training for respite care for family members, etc. They want to see, again, they want better tracking to show that those benefits are, number one, being utilized, and number two, they're improving the health outcome. Right? If they can do that, it can increase better star ratings. They want enhanced flexibility in the benefits. MA plans may tailor the benefits to meet specific social determinants of health needs in their service areas, right? And that again, kind of is more emphasis placed on if you're in a rural area, we want to see enhanced programs for those people for telehealth services, etc. They're also saying community partnerships. Plans should collaborate with local organizations to implement social determinant of health initiatives, including nonprofits addressing food and housing insecurities, faith-based organizations providing community support, public health departments for vaccination drives and health education. And then again, innovative technology solutions so that they can better enhance telehealth services for the people that are less accessible, I should say. So move on from that one. That one's pretty big. The next one is dual eligible plans. Not a ton of stuff in this one. And again, this is just emphasizing, at least this section is emphasizing things they've already talked about, right? They have enhancements coming for dual eligible plans. They're going to be better for the plans, better for the beneficiary ultimately. It's going to end up reducing the total number of dual eligible plans that are available in any given market, right? We already know that there's integrated plans, et cetera, et cetera. So they're pressing on that a little more here, right? So here's the proposed changes for dual eligible plans. Number one, integration of Medicare Medicaid benefits. CMS is emphasizing a greater integration of benefits to ensure a seamless experience for the dual eligible beneficiary. So enhanced DSNPs. DSNPs must better integrate Medicare and Medicaid benefits, offering beneficiaries a one-stop shop for all their healthcare needs. This includes coordinating care across Medicare and Medicaid services and providing a single point of contact for beneficiaries to address coverage questions. They want to see aligned provider networks. Plans will be encouraged to develop provider networks that work across Medicare and Medicaid to reduce fragmentation. They want a simplified enrollment process. CMS proposes simplifying the enrollment process to reduce barriers for dual eligible individuals. Streamlined enrollment. Listen close. This allows for automatic or passive enrollment into integrated plans where appropriate to ensure beneficiaries receive coordinated care. Improved communication. Beneficiaries will receive clear, simplified information about their coverage options and how to access care. Here's the part that made me think. Passive enrollment. What does that mean? Well, let's look. Passive enrollment is a mechanism used in Medicare and Medicaid programs to streamline the process of enrolling dual eligible beneficiaries, those eligible for both programs, into integrated care plans. Under passive enrollment, beneficiaries are automatically assigned to a specific health plan unless they actively choose to opt out or select a different plan. This approach is particularly relevant to dual eligible special needs and other integrated care programs. Key features of the passive enrollment. 1, automatic assignment. Beneficiaries do not need to actively select a plan. Instead, they are automatically enrolled in a predetermined plan based on, number 1, their eligibility for both Medicare and Medicaid. Number 2, regional availability of integrated care plans. 3, prior enrollment into similar plans. So if you have a prospect out there that has already been enrolled in a DSNP and there's a really good integrated care plan in their area, they could be automatically moved into that integrated care plan. That's what they're talking about with passive enrollment. Opt-out option. Beneficiaries retain the right to opt out of the assigned plan and either return to original Medicare, choose another MA plan or DSNP, or enroll in a Medicaid-only plan, depending on their state-specific rules. Notification requirements. Beneficiaries must be informed about their enrollment through clear, timely notices. For example, a letter explaining the automatic enrollment of them into the new plan that it moved them to through that passive enrollment. Why are they looking at passive enrollment? What are some of the reasons for that? Well, they believe it will promote better care coordination. That passive enrollment encourages beneficiaries to join integrated plans that align Medicare and Medicaid services, reducing fragmentation, improving care outcomes. Simplify transitions. It will help beneficiaries transition from one program to another, particularly when a state implements a new integrated care program or a plan is discontinued and beneficiaries must be moved to a new plan. Really, it's going to increase enrollment in the integrated DSNP plans, right? Many beneficiaries are unaware of integrated care options or find the enrollment process confusing. Passive enrollment increases participation in programs designed to provide comprehensive coordinated care. Well, of course it would. If you're going to passively just enroll everybody into an integrated plan, then yeah, it's going to increase the enrollment of them 100%. And the goal ultimately is to improve their health outcomes. Integrated care plans often include case management, care coordination, additional benefits that address the complex needs of the dual eligible beneficiary. So there you go. That's the dual eligible stuff. And there are areas, you probably have already seen them. I've run across some of the Humana integrated dual SNP plans in Illinois, Chicago area already. I've seen a few others that are out there. So as you may already know, right, in any given state, certain carriers, providers have the actual Medicaid contract, right? And they're not a lookalike DSNP. They like in Texas, depending on the region, it pretty much boils down, depending on the region, Molina, Anthem, and UHC are kind of the main three, as I remember, right? And certainly Molina and UHC, they have the Medicaid contracts. They have integrated plan options. So there's a really good chance that we're going to see some beneficiaries passively enrolled or automatically moved over to those integrated care plans depending on their situation. And that's especially going to be true as they start thinning the total number of DSNP plans out, because their goal is to thin the number of available DSNP plans. So for example, if United Healthcare offers a DSNP plan right here in Williamson County, Texas, where I'm at, they're only going to offer one, or maybe one HMO, maybe one PPO. but they're not going to have 4 or 5 different D-SNP plans. They're going to have one, right? And then the goal is to thin it down all the way to only the carriers that have the integrated Medicaid contract. So if, for example, if there's only 2 carriers that have the integrated Medicaid contract in Williamson County, and let's say it's UHC and Molina, then those are going to be the only D-SNPs you see. And if they're on a different D-SNP that gets canceled when they make that transition, those people are likely going to be passively enrolled into the integrated plan with or without you. Now, they can opt out of it, but that's kind of where they're going with this, right? Whew. Crazy stuff there. CMS's role in passive enrollment, approving passive enrollment policies. CMS must approve any passive enrollment processes to ensure that beneficiaries are notified in advance, that they have an opportunity to opt out or select a different plan, and certainly that the process complies with Medicare and Medicaid rules. They have to monitor the outcomes. CMS has to track metrics such as beneficiary satisfaction, enrollment retention rates, and health outcomes in these integrated care plans. Fairly simple. Moving along, and this is when we're getting to the good stuff. These are the last 3 topics. This is all about promoting an informed choice, right? And I said earlier, they have 3 levels of promoting informed choice. One of them is to format provider directories for the Medicare Plan Finder on Medicare.gov. The other one is to expand agent and broker requirements regarding Medicare Savings Program, Extra Help, and Medigap. And the third one is enhancing review of Medicare or of marketing communications and so forth. So let me get back to that real quick. And we're going to pick it up. Medicare Plan Finder. I'm not going to go too deep in this one. It's pretty simple. And I tend to agree with what they're doing here, especially if what they're doing here is going to spill over to some of the other enrollment platforms that we as brokers like to use, such as Sunfire, Connexture, Ascend, whatever, right? So we know what the Medicare Plan Finder tool is, right? It's the tool on Medicare.gov. People can go and they can research plans on their own, punch their doctors, their drugs, et cetera, and look at it. So here's the current issues that they have found. And the big one we know is inaccurate information, right? Provider directories often contain outdated or incorrect information about provider availability, locations, and participation in networks. It's a complex format. Beneficiaries find it difficult to compare provider networks across plans due to inconsistent formatting. Limited accessibility. Beneficiaries with limited English proficiency or disabilities, they might struggle to navigate those directories. So here's the key proposals. Number 1, a standardized format of provider directories. So CMS is proposing a requirement for all Medicare Advantage and Part D plans to submit their provider directory data in a standardized format. Makes sense to me. Why shouldn't we have a standardized format that they all have to use when they're submitting their directories? That will ensure consistency across the entire tool. Right. And I'm hoping, like I said, that stuff like this spills over to things such as Sunfire Connector as well, because that would be outstanding if every carrier submitted in a standardized format. You'd have less inaccuracies. Right. So it'll be very easy to compare networks across different plans and quickly identify whether preferred providers are in network or out. Next one, enhancing accuracy and timeliness. Plans must update provider directory data more frequently to ensure accuracy. The example they threw out was every 30 days. Don't know if that's what they're going to use or not, but that's an example that they said, like, hey, we want the plan sponsors to give us or update their provider directory more frequently so that it's accurate, and we're recommending at least once a month. And they will also want them to include real-time information about whether providers are accepting new patients, the provider contact details and office hours, and any specialties and services they offer, such as telehealth availability, for an example. They want all of that to be included. And now I'm saying this is for Medicare.gov's Plan Finder. Whether or not all of this would make it somewhere else, I don't know. But I'm hoping that if they're going to do it there, we'll see it on some of the broker tools as well. They want to simplify the presentation for beneficiaries. The proposed rule focuses on making directories easier to navigate and understand by using clear labeling and organization. Searchable filters for different languages, locations, provider type, etc., and include visual aids like maps to show provider locations. They also want it to include key information such as the proximity of providers to the beneficiary's home. I think some of that is already in there. Another big one is language directory or language accessibility, right? Offer directories in languages other than English for local beneficiary demographics. So they want to include a feature to search for providers who speak specific languages. Transparency about provider networks to prevent confusion. CMS proposes requiring plans to disclose limitations of networks, such as whether providers are only available under specific plan tiers, coverage variations for out-of-network providers. Fairly simple, right? So the idea is obviously to primarily update the Medicare Plan Finder tool to have better accuracy for all provider directories, starting with the standardized format and including additional details so the people can really drill down to find the right provider. All right, moving along. I'm trying to get this speed up so we can get through the whole thing. We got 2 more. Also under promoting an informed choice, expand agent and broker requirements regarding Medicare Savings Program, Extra Help, and Medigap. We know what those programs are, so I'm not going to go into the details even though they relist them in here. But here's what they want us to do as agent and brokers. Agents and brokers will be required to provide accurate, comprehensive information about Medicare savings programs and extra help to eligible beneficiaries. They must assist beneficiaries in understanding how Medigap plans can complement original Medicare to reduce out-of-pocket cost. So they want to make sure that we are absolutely talking about Medigap as an option. And I would think most of you agents are. I know I certainly do. Matter of fact, any beneficiary that ever comes to me, that's the first thing I do is I try to sell them a Medigap plan. I'm like, here's how Medigap works. This is, in my opinion, the better coverage for you, or what most of my clients like to choose. And a lot of them, they're going to have to ask me about Medicare Advantage before I ever bring it up. So I'm already in compliance on this one, and hopefully you will be too. But it goes on. Screening for eligibility. New requirement. Agents must screen beneficiaries for potential eligibility of Medicare savings programs and extra help during plan consultations. They must use state-specific income and resource thresholds to identify beneficiaries who might qualify. And they must inform beneficiaries on how to apply for these programs. This is not an optional thing. This is not you being a good agent, right? We talk about Medicare savings program all the time to our target market. But now they're going to say you have to do it, and you're going to have to document that you're doing it. Application assistance. Agents and brokers must offer assistance in applying for Medicare savings programs and extra help, which may include helping beneficiaries locate state Medicaid offices or online applications, and providing resource and guidance on the required documentation that they would need to fill out those applications. Incorporating Medigap into consultations, already missed that, but again, that is now a must. Agents must include Medigap options in their discussions with beneficiaries, ensuring that they understand how these policies can reduce cost under original Medicare. And it's particularly critical that we discuss Medigap. I'm reading this verbatim. Particularly critical that we discuss Medigap to those beneficiaries who are not eligible for Medicare savings program or extra help, but would still face significant out-of-pocket cost. Increased documentation. CMS proposes requiring agents and brokers to document their discussions and efforts to educate beneficiaries about these programs, ensuring transparency and compliance. What are some of the impacts on agents and brokers? Well, increased workload and training requirements, right? Agents have to be well-versed in the eligibility criteria for state-specific Medicare savings programs and the federal extra help program, which means we're probably going to see more education maybe within AHIP, maybe within carrier certifications, because it says right here, ongoing education may be required to keep up with changes in those program rules. Medigap training. Brokers must enhance their understanding of Medigap policies. Medigap policies really aren't that hard, am I right? Come on. Administrative burden. Screening beneficiaries for program eligibility and assisting with applications adds to agents' administrative responsibilities. Maintaining detailed documentation of consultation and applications assistance might require some additional resources and tools. No kidding. You really think so? Whew. So a lot there. Moving along to the final piece, the one you've all been waiting for. They always put it at the bottom, right? Let me get to it, man. There's a lot more. I'm probably going to do some follow-ups on this, on some of these specific topics, because just to give you an example, like this whole section on Medicare Savings Program, Extra Help, and Medigap, it's deep in some of the requirements, the detailed notes that we're going to have to take, some of those different things that we will have to prove that we are doing, screening, documentation, updating initial consultation questionnaires, all of that type of stuff. So I'll do another one on that. But let's get to the final one, the big one, right? The big one, the one you've all been waiting for. Enhancing the review of marketing and communication. So there's already been some talk about it. There's already been some hyperbole, some misleading information possibly about their whole thought process on enhancing the review of marketing and communications, right? One of the things that they specifically said is they want to broaden the definition of marketing and communication. They want to broaden that definition because they know that there's misleading information out there. And I'm going to go into some of it and I'm going to point out a couple of gotchas. A lot of this, again, is already redundant. A lot of this is stuff they're already doing, right? Misleading information. We're not allowed to use terms like free benefits already, but they re-listed it in here. Like, we can't say that. I can't run an ad that's like, hey, get all the free shit. I got it for you. Call me up now. Right? We already can't do that. We also can't use high pressure tactics. That's relisted in here, right? Pre-approval of materials. That's already a requirement, but they relisted it in here again, right? You can't create your own materials that talk about specific plan benefits. That's the whole key, and it's been like that forever. I mean, I remember in circa 2005 when I was working with United Teacher Associates, and we wanted to do a mailer to agents, not to consumers. We wanted to do a mailer to agents promoting our $99 Plan F that we had in Texas for recruiting purposes. Well, as we should already know, you cannot make any advertisement, postcard, business card, flyer, website, video, doesn't matter, that promotes any specific carrier names, benefits, or costs, period. It's been like that forever. It's nothing new. We've never been able to say those items without approval, one from the insurance carrier that we want to promote their rates, benefits, or plan specifics. And then number two, the state, or now in this case, CMS. So when we wanted to make that mailer showing off our $99 Plan F, first thing we had to do was talk to United Teacher Associates right there on the third floor and be like, hey, we want to promote this mailer to recruit agents. $99 Plan F in these zip codes. How do we get it done? We came up with the language, got it all done, and then boom, we didn't have to submit it to Medicare, but we did have to submit it to the State Department of Insurance in Texas to get their approval. So it's not necessarily any different here, right? You still can't create materials that promote carrier specifics, plan benefits, rates, etc. Period. Can't do it. And if you do it, you got to get approval from the carrier, and then you got to get approval from Medicare, CMS, right? So if you want to create a special advertisement to market, say, devoted give back plans in the Houston area because they're hot, as an example, I'm just being arbitrary, you're going to have to, one, come up with the ad, give it to Devoted, work with them to get it their approval, and then next file it with CMS and get their approval. Probably an incredibly long process. But don't fret. It's not as bad as it sounds, I promise. Because there's been some people saying, oh no, agents aren't going to be able to send out business cards or flyers or any of this. No, that's all bullshit. No offense to the guy that put that video out there and was being very dramatic and say we have to get business cards approved by CMS now. No, you don't. You would only have to get your business card approved by the carrier CMS if it has plan-specific benefits, rates, or information on it, or carrier names, right? So you wouldn't be able to create a business card that says, I offer Devoted, Aetna, United Healthcare, etc. That's off the table. But you can still keep your generic business card that says, hey, call me, I'm an insurance agent. Happy to help. And these are some of the products I can help with. Medicare supplements, Medicare Advantage. I can do all of that. I just can't say the specific benefits. All right. But let's go on because there's definitely some stuff to be concerned about. Whew. They want you to create, if you are going to submit something, they're going to have standardized templates for the type of item, right? So if maybe you have a landing page that promotes carrier rates, benefits, or specifics, and you want to get that filed, they're going to have a standardized template for that type of advertisement, for a brochure, for an email item, things of that nature, right? They're going to create standardized templates that you can use to submit. Marketing materials, as always, they got to have clear disclaimers. They put it on here again, but that's nothing new. We already know that we have to have disclaimers such as this is not a government program. We're not endorsed by the federal government of Medicare. We don't offer every plan in your area, blah, blah, blah. They just relisted it again because they think it's important, but it's not new rules. Couple of things. CMS plans to increase random reviews of marketing materials, even those that are not submitted for pre-approval. Proactive monitoring. CMS will use new tools such as beneficiary complaints and third-party audits to identify non-compliant marketing practices. That's not necessarily new. Fairly simple there. A few enhanced rules for agents. Agents must ensure that all information providing during enrollment discussions is consistent with approved marketing materials. That's really nothing new either, right? So again, a lot of this is redundant. We know that if we go and do a presentation, we can't recreate Devoted or United Healthcare sales materials and brochure that talks about plan benefits, et cetera, et cetera, et cetera, right? We have to use their approved materials. Again, nothing new there, period. Agents may be required to document all marketing interactions. That's a step up. We're already having to record calls, but they're talking about increasing the level of documentation we have to do in our marketing activities. So if you don't have a CRM and you're sticking around in the Medicare space, you need to go get a CRM because you're going to have to start documenting more stuff. Again, assuming all this goes through, which it probably won't. Just being honest. But I want to, this is good content, right? All right, moving along. Enhanced documentation. Here it is. Agents will need to keep detailed records of their marketing activities to demonstrate compliance, including a copy of the scripts that you use in the calls. It's not enough that you're recording the call. They want a copy of the script that you use to make calls. They want copies of any distributed materials that you send out. And they want notes from your enrollment discussions. So you're sitting there having a conversation with Margaret Jones, and you're making notes in your CRM that help you keep track. Well, they're going to want those now. Agents will need additional training to understand the updated marketing rules and ensure compliance, yada, yada, yada. They already put that in AHIP. Prohibited practices, nothing new here. Unsolicited contact, no cold calling, no door-to-door. They're just saying it's going to be monitored more strictly. Sure, it will be. But that's what they're saying, right? We already know we can't go door-to-door and try to sell a Medicare Advantage plan. You can definitely go door-to-door. You just can't do it with the intention of selling a Medicare Advantage plan on that visit. I can definitely cold call a senior. I just can't do it with the intention of selling a Medicare Advantage plan or a drug plan on that same single phone call. And in Ohio, you can't cold call anybody 65 and up, period. Right? So they're saying that they are going to monitor that more strictly. They're also saying that misleading advertisements, such as implying the CMS endorsement or using Medicare logos improperly, will face harsher penalties. I don't know what the penalties are right now because I don't think they've ever been clear about them, but they're saying whatever they are, they're going to be harsher. Agents must stick, this is still also redundant. Agents must stick to topics agreed upon prior to the appointment. Scope of appointment, we already know all that. right? And we already know that we have to record calls. They hit that one again, but we already got to record calls. Nothing new there. I want to get to the more important piece because there's been some talk about educational content getting monitored. And they're saying that there were some people that were saying that, hey, even if you had a YouTube channel that educated people about Medicare, that would be on the block for CMS approval. Not necessarily. There's one gotcha. And this is the piece that I want to say that they got you on. And this is the piece that you as the agent need to make sure that we comment and we reply to these people. So just bear with me. I thought I had it highlighted. I think it's all the way down here at the bottom. Here we go. What might trigger a CMS review or approval? We already know mentioning plan specifics or carriers, right? So if I have my YouTube channel or I make a social media post that mentions a specific carrier or mentions a specific benefit from that carrier on that plan in that zip code or whatever, that obviously is going to trigger some monitoring and need for CMS approval. Here's where the educational piece, because again, you can still do education, no problem. Here's what you can do without CMS approval, and this is per their guidelines. I can do educational videos with topics like how Medicare Part D works. What is the Medicare Advantage open enrollment period? How do Medigap policies work? I can do all of that stuff. General guidance discussing cost savings programs, enrollment periods, high-level plan types, like the difference between an HMO and a PPO. All of that's still good. I do not need CMS approval to educate people at that level. Here's where I might have trouble. If that content is designed to generate leads, in other words, I'm using an educational video, but then I drop my phone number at the bottom of the video. Call now for more information. That might need CMS approval. But I can still put out the content. I just can't drive them to a call to action. That's the gotcha that's in there. That's the only one I can find. I went through this thing with a fine-tooth comb. Everything from an advertising standpoint has really not changed at all. All they're doing is now they're adding this one little thing in there that says, well, if you are doing educational content and you're including a call to action to use it as a lead generation mechanism, that could require CMS approval. That is the meat of it, man. So there you go. That is what I've got for you guys today. I hope that maybe clears up some of the confusion out there. I'm probably going to do a few follow-ups on this, particularly in going through the Medicare Savings Program requirements and all of that, because I've got some ideas on how agents can streamline and implement that easier. Same with some of the Health Equity Index. I want to go through some of those in deeper. I couldn't get through. I mean, just to give you an example, this thing is 714 pages. And I went through with the fine-tooth comb and I made 66 pages of notes. I mean, the font's pretty big, but I got 66 pages of notes that I've gone through as I've been picking through this thing. So, and I couldn't get through all 66 of them with you guys on the phone or on the call today. I just went through them as quickly as I could and hit the very, very, very specific pieces. So there you go. That's the day. Have an awesome day. Again, all this stuff is already in the group. You can go find the fact sheet. In the fact sheet, you'll find the full link or the link to the full PDF. And you should also see the comments I made on the different people that you can contact to submit your comments, questions, concerns, etc. So if I'm you, I would take some time, write a letter, talk to your congressman, your representative, express your concerns about this, and let's all do what we can to keep our industry safe and lucrative and profitable and long for agents and brokers. Have a great day. We'll see you next time on Tuesday Training.